Okay, thank you.
And okay, okay. Good evening, everybody, for giving me this opportunity to share this talk. It's truly a privilege here to speak with all these great experts around the world. So I'm going to just give a little bit of update over the last decade in laparoscopic inguinal hernias, and actually, don't need to say. So it's made my job easy. So as Ashley Cooper said, that no disease in the human body, a better combination of accurate anatomical knowledge and skill than hernia and all this. From tissue repair to mesh repair to tension-free repair and now to laparoscopy, all in the aim of trying to preserve the anatomy, to reduce the short and long-term recurrence, as well as reduce post-operative pain. Inguinal hernia, of course, is, you know, the most common procedure, and now it's increasingly done laparoscopically because of less postoperative pain and early return to activity. As you all know, there's TAPP and TEP. TAPP, and as discussed before, is slightly more technically challenging, but of course the advantage is that it reduces the risk of damage to intra-abdominal organ. When you compare TAPP and TP, the learning curves, in general, it's between around 40 to 100 cases. TEP is slightly longer learning curve since it's a bit more challenging, but when taught correctly, it's actually very, again, Dr. Ghafoor said there's a more chance of conversions in the learning curve. But once you get past that, then it's very sexy. But between TAPP and TB, all the studies that have been done so far have shown that there's no evidence of either being superior to another. It all go from there. So the learning curve, I would say in the decade before this, the learning curve, we were still on the learning curve of laparoscopic inguinal hernia. We were somewhere here between the associative phase and autonomous, but in the last decade, we've almost become now an autonomous stage. And our journey from a beginner to expert is now shortened, and this is having expert proctors to mentor us, attending all these MIS fellowships, having laparoscopic training workshops, and especially, in this area, in Korea and especially Thailand, they've done great cadaveric workshops and held, they've held it, and now it's kind of become standardized. We have looked at the volume, and it shows that if you have a higher volume, the main thing is to standardize this approach. So in ELSA, we have kind of standardized our hernia into 8 steps in teaching the residents to reduce their learning curve. In the updates now, I'll talk about the meshes a fair bit, what we use, changes in fixation over this decade, and some additional modifications in techniques. So as you all know, endoscopic has lower chance of wound infection and early return to activity, and endoscopic surgery is slightly superior when you can talk about pain. The era when it started was that lightweight was being propagated, but now we use lightweight very selectively because we have to see what the size of the defect is. In small hernias, lightweight has an advantage. However, sometimes if you put a very lightweight mesh, then you can get something like pseudo hernias. So we'll talk about a bit of that later. And looking at this study, you can see that in large hernias, when they compared lightweight versus heavyweight, lightweight had more recurrences. So the current teaching is, of course, that if you have indirect hernias in small hernias, then you can use lightweight. But if you have large in Asia, we have the 3D. We have a ProGrip self-adhesive mesh, which doesn't require fixation because it actually fixes well to the muscle. And the Pyretex DP2, which can actually wrap around the cord. This is my personal. Now we'll talk about fixation. The main issue of why there is this between decreasing our recurrence and decreasing pain and cost. Mesh has been commonly, fixation has been commonly used by surgeons, but of the higher risk of chronic pain. And you can fix hackers. And when you put a metallic tank in this particular area called as a triangle of pain, which is bounded medially by the gonadal vessels, laterally by the myopectineal line, and inferiorly by the peritoneum, and it carries the lateral cutaneous nerve of the thigh and branches of the femoral nerve, which if you tack on can result in chronic pain. So this is a tacky issue because why people started tacking was there are a lot of studies. This study showed that there's inadequate fixation, especially on the medial side, because as you all know, laparoscopic or even in open, and people that there was a recurrence because it was not fixed there and meshes migrated. Another large study, 10,000 over, thought that this was inadequate lateral fixation. And so the question came, is stapling necessary or tacking necessary for hernias? And ultimately we came to the conclusion that for small hernias, you probably don't need to fix it, but for large hernia to do some sort of fixation. And there's still always this, ball being tossed around from court to court. So they tested whether this mesh migrates in the early postoperative period and got this patient out, flexed him, extended him back, and they found no recurrence. But I can say that in the early days when we, didn't fix, we did have some patients who immediately coughed out of anesthesia and got a very, very early recurrence. Not to fix, they found that there was no difference in recurrence rates. However, the cause, and again, we discussed about pain and the triangle of pain. And also because when the tackers first came in, people started tacking, they went a bit crazy and tacked like this. And of course, this resulted in, very bad pain, especially having metal tackers. So, and compared between fixing and no fixing and found no recurrence difference between either group. Again, another very important trial to look between staple and non-staple. Now, this study is very important because it looked at difference in pain in terms of how many tacks you put. And when you put less than 6 tacks in your inguinal hernia, there is significantly lower pain. And now it is a standard care that try not to put more than 6 tacks. The lesser the better, just in key places. And where are the places? One here at the pubic symphysis, one in the anterior abdominal wall here, and you could put one along the side, along the inguinal ligament, and maybe one in the lateral side. So 3 to 4, just to keep it in place, would be an ideal situation of putting a tack. Now the evolution of tacks too, from metal tacker, it is moved to absorbable tackers, these are made of proteins, which actually get absorbed over time, and therefore decrease the chance. This absorber tack is also a bit ergonomic, and we'll talk about it in the next slide. And these are the current tacks that are available. And if you look at comparing the metal tack versus the absorbable, let's say the absorber tack, the metal tack is a helical screw. Basically, when you tack it, it's like it has a centripetal force, and therefore it actually pulls the surrounding tissue inside it. And therefore, if you tack near a nerve, this has a risk of actually getting trapped within this. Whereas the absorber tack is as a centrifugal force, and when you tack it, tissues that are nearby are displaced away, and therefore even if you're near a nerve, you have a chance of pushing it away. Silverfix works on the same principle, and secure strap actually is a loop, so that even if the nerve is within this, it's not completely compressed. The advantage, of course, is that all these are absorbed. Nevertheless, they still cause a variable degree of pain, any fixation device. So the next issue was that the size of mesh. And now over this decade, we have actually confirmed that you need at least a 10 to 15 centimeter size that will actually overlap pretty well. You should make sure that your mesh overlaps the midline, it overlaps your obturator foramen, femoral ring, the deep inguinal ring, and lateral enough overlap of about 5 centimeters. If your hernia is large, then you need a slightly larger mesh, about 12 to 17 centimeter. Now, in terms of tack, when we looked at metal tack versus absorber tack, we did a study and we compared these two tacks, and these were the metal tack versus absorbable tack, and you can see that metal tack had a higher postoperative hematoma rate, seroma rate, and the postoperative pain to over 6 months was much less in absorbable tacker versus metal tacker, and therefore I would highly recommend to not use a metal tacker at all and use just absorbable tacker if you're using a fixation device. So the other type of fixation is glue, and the fibrin glue was one of the first glues that were used. And this has got, comparing, we will look at the studies. There are some issues though about biomechanical stability, longer operative times, and in terms of fibrin glue, higher rates of seromas. So these are studies to compare fixation with the stapler versus glue, and you can see that there is in chronic pain in favor of glue. Another meta-analysis to compare the two, and again you can see that the glue fixation did not increase the risk of hernia recurrence, reduce the risk of chronic pain. And this one, when you look at meta-analysis of randomized trials, you can see that in terms of comparing it with recurrence, fixation with stapler had better outcome. In terms of seroma, was less in terms of glue, and overall both were similar, but in terms of chronic pain was less in fixation. This is a meta-analysis of randomized trial comparing pain, and glue was much superior towards staple fixation. Now the glue itself has evolved in this decade, and from fibrin glue we have now moved to cyanoacrylate glue. And because there were some issues with glue in terms of clogging, etc. in terms of fibrin over the mesh, it was very difficult to control this. We used flexible tube and as well as catheters, but we couldn't get it uniform. So how have we overcome this in this decade? We started using this thing called as a liquid band. So liquid band is an instrument that actually delivers glue in a very systematic manner. And fibrin cyanoacrylate glue, as you all know, they're monomers. And when these monomers mix with blood and water, they join together to form polymers, and these form a solid bond within about 10 to 20 seconds. Now, this will actually fire a round of glue, and you have about 6 in different places. If you press and hold the piston, it will actually leak it in a systematic manner. So in certain areas, if you want to apply more glue, you can fix it, and then those areas you can put a bit more glue. So here's a video of me doing this. In this, I'm using a Dynamesh, and we place it. You can see the liquid band being used. And this is a much better delivery system, has overcome the discrepancies of the flexible tube and keeping it in place. So once we fix the mesh in place, you use this liquid band, and you can go to that place and just click it, and then it actually delivers here. So the advantage here, of course, is that you can use it over the triangle of pain, triangle of doom, etc., without having to worry about chronic pain or injuring. It irritates these structures. But currently, it is proven to be. You can also use this in TAPP to basically close the peritoneum after you're done, if you're judicious in the use. So you can use the glue to actually close entire peritoneum, and also tack can give the risk of adhesions to structures, and this actually fixes pretty well. And you can see in this video that you're just using the glue to fix the peritoneum. So make sure that you put that glue in the inner side, and then just roll your fixation device over it. And so here you can see this glue being used to cover the peritoneum. So this is pretty easy to use, and it's actually quite fast, right? So I did about last year. It was introduced in my previous hospital in Tan Tock Seng, and I did about 13 cases with it, and it has good fixation. The pain scores are very minimal, 0 to 2, and we didn't have any case of seroma, hematoma, or recurrence. So of course, this one, try not to use the piston touching. You just keep about a little bit of head up position, and fix both meshes, right? So now there's a grade 1 recommendation that fixation with glue is better, causes less pain. Okay. Now, like seroma and recurrence, the recurrence rates, has been up, especially in terms of different types of hernia, and especially in large hernias, the laparoscopic rates have been high. Inguinal-scrotal hernias also, patients with high BMI, large defects, and how we've been fixing. And the most important problem is that of direct hernias. How do we fix these direct hernias? Because when we put the mesh, we found that there's an increased rate of seroma as well as recurrence. So there are various techniques available. One is the tacking, one is and using basically by closed primary, we were able to decrease seroma rates to about 1% by putting this endo loop. So you can pull the transversalis fascia in and use an endo loop to fix this. So this is one of the techniques, and it's now recommended, but it has a low level of recommendation that you can use this in terms of small direct hernias. But when it comes to large direct defects, this may not be the best. Some have been using tacking. So you pull the transversalis fascia down and you tack it to the pubic bone. And in this case, the seroma rates have been reduced to about 4%. May not be suitable, and of course it requires tacking by metal tackers. So now in the current recommendations is a grade B recommendation that if it's a large hernia, you can actually do some form of fixation, either by use, and they've brought the reduction of seroma rates from 15 to 5%, and the volume too. And these are surgical drains, a Chinese study where they decrease the seroma rates. However, now keeping surgical drains is not, etc., and it's more inconvenient. So suture closure has been used to close a large direct defects. And let's see how this is done. And we've called it the TEP plus technique. So TEP plus technique is basically when you have a large defect, we push the two ends of the transversalis fascia. We can even close it to the rectus muscle here, bring in the transversalis fascia and take a suture through it. If it is a smaller defect, you can use interrupted sutures using proline and like a Roder's knot, you can close it. But for larger defects like this, you can put in a barb suture. If you have a difficulty with the curve, close the defect. So this is a technique that you can use to bring this defect closure. And this is on the other side. It's bring the transversalis fascia into it and not just suturing the other side. And this almost completely, seroma rates.